Okay, let's unpack this. You've come to us with a stack of fascinating sources,
Yeah.
all about a part of your body that often goes completely unnoticed until something goes wrong,
Right.
your salivary glands.
Yeah.
Today, we're going on a deep dive into these, well, unsung heroes of your oral health.
Indeed. They really are. These small glands, they do so much more than just produce what we, call spit.
Uh-huh.
Understanding their intricate functions
Yeah.
and the array of conditions they can develop is absolutely key. Key to appreciating their vital daily contribution to your overall well-being.
Yeah, impacting everything from speech to fighting germs, you said.
Exactly. Your ability to speak clearly, your body's frontline defense against unwelcome pathogens. It's all connected.
Okay, so our mission today is to give you, the listener, a clear, engaging understanding of these powerhouses.
Right.
We'll explore their kind of hidden anatomy, their incredible daily output, the tools we use to diagnose issues, and then dive into the spectrum of conditions, both non-cancerous and cancerous, that can affect them. Prepare to be genuinely amazed, I think, by what these little glands are doing right now.
Absolutely.
So, kicking off our exploration, let's start with something I found pretty surprising. Most of us know the big three, right?
Huh.
The major salivary glands, parotid, submandibular, sublingual.
The main players, yeah.
But did you know you also have hundreds, possibly even, up to 1,000 minor salivary glands?
It's true. Hundreds of tiny lobules tucked away throughout your mouth, your throat, even in your sinuses.
Wow, all over the place.
Exactly. And what's fascinating is how they specialize. The parotid, for instance, it gives us primarily serous saliva.
Serous.
Yeah, that's the thin, watery kind. Viscosity of about 1.5, if you want the number. It's perfect for initiating digestion. Contributes about 25% daily.
Okay, thin and watery from the parotid. What about the others?
Then you have the sublingual and many of those minor glands contributing mucus saliva.
Ah, the thicker stuff.
Much thicker, yeah. Viscosity more like 13.4. Provides essential lubrication. It's actually a smaller daily contribution overall, though.
So a thin one for enzymes, a thick one for lubrication. But which one handles the bulk of the work?
That would be the mixed saliva. And that comes predominantly from your submandibular glands.
Ah, the ones under the jaw.
Right. They are the champions, producing a whopping 71% of your daily saliva, viscosity around 3.4. It's a balanced mix, good for both digestion and protection.
Okay, here's where it gets really mind-boggling for me. The sheer volume. You produce an astounding 1 to 1.5 liters of saliva every single day.
It's incredible, isn't it? 1,000 to 1,500 milliliters daily.
Imagine drinking that much liquid just to keep your mouth moist, let alone do everything else.
Exactly. It's a huge, tireless output, and those functions are truly multifaceted.
More than just moisture.
Oh, much more. Beyond lubrication for, comfortable speech and chewing, saliva kickstarts digestion with enzymes like amylase. And crucially, it also acts as a frontline defense. It's packed with antimicrobial properties to protect you from oral pathogens. And all of this is precisely controlled by your autonomic nervous system. Cranial nerve 9 for the parotid, 7 for the submandibular and sublingual. It's just a testament to the body's intricate design.
Incredible control. And these major glands, they have their own plumbing system, right? Ducts.
That's right. Dedicated plumbing. We're talking about Stenson's duct from the parotid,
Okay.
which opens near your upper back molars, the second molar usually,
Uh-huh.
and then Wharton's duct from the submandibular and sublingual glands.
Then where does that one open?
That opens right in the front floor of your mouth. You can sometimes see the little openings. But what's fascinating, as you said, is how these vital pathways, these ducts, can also become points of vulnerability, blockages, stones.
Right. Okay, so when these unsung heroes start sending distress signals, maybe swelling, pain, how do we begin to unmask the problem? What's the first step when something feels off?
Well, the initial step is always a thorough history, talking to the patient, and a careful clinical examination. Feeling the glands, looking inside the mouth.
Makes sense.
But from there, we have quite an array of diagnostic tools. For instance, if we suspect those pesky siloliths.
Salivary stones.
Salivary stones, exactly. Plain X-ray films can sometimes be useful, especially for the submandibular gland. About 80–85% of those stones show up because they're radiopaque.
Okay.
But in the parotid gland, only about 40% are visible that way.
So x-rays aren't always enough.
Often not. For precise location and really detailed imaging of the stone in the gland, a CT scan is invaluable. Much better detail.
I can see how knowing the exact location would be critical for treatment.
Absolutely. Now, if we need a detailed look at the ductal system itself, the plumbing,
Yeah.
silography was historically the gold standard. It involves injecting a contrast dye into the duct.
Okay.
It can pinpoint obstructions, inflammation, strictures, and sometimes it can even therapeutically flush out small stones or mucus plugs just by doing the procedure.
Oh, interesting. A diagnostic and potential treatment.
Sometimes, yes, but there are key contraindications. We absolutely cannot do it if there's an acute infection present or if the patient has an iodine allergy because of the contrast dye.
Got it. Important exceptions. And when it's not just a blockage, maybe, but a question about the gland's tissue itself, or maybe a suspected mass.
Right. For that, ultrasound US is often a great starting point.
Ultrasound.
It's non-invasive, it's quick, uses sound waves. And because the major glands are pretty superficial, right under the skin,
Yeah.
ultrasound can easily distinguish between fluid-filled things like cysts and solid masses. It's claimed to be superior to silography in some specific situations, and it can even guide needles for aspirations or biopsies.
So quite versatile. Any downsides?
Well, it has limitations for disease in the minor glands, which are deeper or scattered. And crucially, the accuracy really depends on having highly trained personnel doing the scan.
Operator dependent, right?
Very much so. But for the most detailed soft tissue evaluation, especially if we're concerned about tumors or potential nerve involvement,
Then what?
then magnetic resonance imaging, MRI, is truly the gold standard.
MRI.
Yes, it provides exceptional clarity of soft tissues, much better than CT for that. It can see minor gland pathology or if a tumor is getting close to a cranial nerve.
Okay, so MRI is the go-to for tumors and biopsies. What's the definitive step for diagnosis usually?
Right. For a definitive diagnosis, especially of mass, a biopsy is key. For the major gland masses, a fine needle aspiration biopsy, or FNA, is generally preferred.
Why that one?
It's minimally invasive, just uses a thin needle. It boasts high accuracy, specificity, and sensitivity, often over 90%, and it can even be guided by CT if the lesion is deep or hard to feel.
Less invasive, high accuracy. Sounds good.
It usually is. No, for the minor glands, like those tiny ones in your lower lip,
Yeah.
an open biopsy is often used. We actually take out a small piece of tissue containing several minor glands. This is particularly important for diagnosing conditions like Sjogren's syndrome.
Ah, okay. You need a cluster of them.
Exactly. You typically need a minimum of 10 glands to calculate what's called a focus score, looking for inflammation.
That's incredibly detailed. Wow. Now let's pivot a bit to the more common issues that can plague these glands, the non-cancerous or non-neoplastic conditions.
Yeah.
Starting with those obstructions you mentioned earlier, the salivary stones.
Yes, silolithiasis. Salivary stones. They actually affect men about twice as often as women, typically between the ages of 30 and 50.
Huh. Any idea why men more often?
The reasons aren't entirely clear, but what is truly fascinating is why the submandibular glands are so much more prone to forming stones than the parotid. Like 80–90% of stones are submandibular.
Okay, why is that?
Well, it's a combination of factors. First, their saliva naturally has twice the calcium concentration compared to parotid saliva.
More building blocks for stones.
Exactly. And it's more alkaline, which also favors precipitation. Plus, Wharton's duct, which drains the submandibular gland.
Yeah, the one opening at the front.
Right. It has a couple of sharp turns. The opening itself is narrower than Stenson's duct, and the saliva actually has to flow against gravity to get out.
Oh, wow. It's like an uphill battle with thicker, calcium-rich fluid.
Precisely. It's almost a perfect storm for stone formation. Stagnation, minerals,
Yeah.
it all adds up.
So the body's own elegant plumbing can sometimes work against itself. What does that feel like for the patient when you have a stone?
Typically, you'd experience recurrent swelling of the gland that's involved. It classically gets worse during meals when saliva production increases but can't get out.
Mealtime swelling, okay.
Often accompanied by pain. And sometimes, if it gets infected behind the blockage, you might see a purulent discharge from the duct opening, or even have a fever.
Ouch. Okay, so how do we tackle these common obstructions?
Well, simple measures can sometimes work. Good hydration, gentle massage of the gland, and using silagogues, things that stimulate saliva flow, like tart candies or lemon juice.
Trying to flush it out.
Exactly. Those simple things can actually help about half the stones pass on their own if they're small enough.
50%, not bad.
Not bad at all. For more stubborn or larger stones, sometimes a doctor can remove them through the mouth, maybe dilating the duct opening. In some cases, surgical excision of the gland might be necessary, but we try to avoid that.
Right, preserve the gland if possible.
Absolutely. And that's where the real game changer has been endoscopy.
Silendoscopy, like endoscopy for salivary ducts.
Precisely. It uses tiny, tiny scopes, like less than 2 millimeters wide, that go directly into the duct.
Wow.
We can visualize the inside of the duct system, find the stone, and often retrieve it with miniature baskets or graspers. We can also dilate strictures or flush out debris.
So you can fix the problem from the inside.
Yes, and the huge advantage is preserving the gland's function. It's minimally invasive and has really revolutionized how we treat obstructive disease. A huge win for patients.
That sounds like a much better outcome. Okay, beyond stones, what about other common sort of fluid-filled issues? Cysts.
Yes, we often see various cystic conditions. Mucoceles are probably the most common, especially on a child's lower lip.
Oh, yeah, I think I've seen those. Little bumps.
Little fluid-filled bumps, exactly. They're usually caused by minor trauma, like accidentally biting your lip. A tiny salivary gland duct gets severed, and mucus leaks into the surrounding tissue, forming a bubble. It's technically an extravasation phenomenon, not a true cyst with a lining.
Okay. And you mentioned ranulas.
Ranulas are basically the same thing, a mucosilla, but they occur specifically in the floor of the mouth associated with the sublingual gland.
Why the funny name?
It comes from rana, the Latin word for frog. They can sometimes look like a translucent frog's belly under the tongue. Most are simple, but some can actually dissect down through the muscles of the floor of the mouth into the neck. We call those plunging ranulas, and they often need a CT or MRI to fully define them.
Sounds a bit more serious.
Can be trickier to manage, yes. We also see silesiles, which are collections of saliva, usually resulting from penetrating injuries that damage a major duct, commonly in the parotid gland. And sometimes botulinum toxin injections can actually help treat those by reducing saliva flow while the duct heals.
Botox for saliva leaks. Interesting.
It can be effective. And one other type, lymphopithelial cysts, are relatively common, again, mostly in the parotid, and are particularly associated with patients who have HIV/AIDS.
Okay. Lots of different types of cysts. What about infections? Sudden pain and swelling.
Right, infections. Acute bacterial silodenitis inflammation of the gland due to bacteria is most common in the parotid gland.
Parotid again.
Yes. It often affects the elderly or patients who are debilitated or chronically ill. It's typically thought to be an ascending infection from bacteria in the oral cavity traveling up the duct.
Going the wrong way.
Exactly. Staphylococcus aureus is a frequent culprit. And dehydration often plays a significant role, reducing the natural flushing action of saliva. Treatment focuses on rehydration, antibiotics that cover staph, and sometimes gland massage.
Makes sense. And viruses.
Well, historically, mumps was the most common viral cause of parotitis, gland swelling. But thankfully, its incidence has drastically dropped since the MMR vaccine was introduced back in 1967.
Good news for vaccines there.
Definitely. We also sometimes see HIV-associated salivary gland disease, often presenting with those lymphopithelial cysts we mentioned, and sometimes gland enlargement.
Okay. This raises an important question, I think. Why does our own immune system sometimes attack our glands? That brings us to autoimmune conditions, like Sjogren's syndrome.
Precisely. Sjogren's is a chronic systemic autoimmune disorder, and it predominantly affects perimenopausal women. The statistics are striking. About 9 out of 10 patients diagnosed are women.
9 out of 10. Wow.
Yeah. It specifically targets the exocrine glands, primarily the salivary glands, and the lacrimal glands, the tear glands.
So dry mouth and dry eyes.
That's the hallmark combination, yes. Dry mouth, which we call xerostomia, and dry eyes, or keratoconjunctivitis sicca. It can occur as a primary condition all by itself, or secondary to other autoimmune diseases like rheumatoid arthritis or lupus.
How's it diagnosed?
It's usually a combination of things. The classic symptoms, of course, then objective tests like the Schirmer's test to measure tear production for dry eyes, blood tests looking for specific autoantibodies like anti-Ro, SSA, and anti-La, SSB. And as we discussed earlier, a minor salivary gland biopsy from the lower lip can be very helpful to confirm inflammation.
And treatment.
Treatment is mainly supportive, unfortunately. There's no cure. So it focuses on managing the dryness with things like artificial tears, lubricating eye ointments, artificial saliva, and sometimes medications called sialagogues like pilocarpine or Sivaline to stimulate whatever gland function remains.
Managing symptoms, basically.
Managing symptoms and preventing complications like dental decay or eye damage.
Now, for our listener, what's a crucial... So what about Sjogren's syndrome that might, surprise them or be really important to know?
I think a really important implication and something patients need to be aware of is that having Sjogren's syndrome carries a significantly higher risk estimates are around a 4% lifetime prevalence of developing lymphoma.
Cancer of the lymph system.
Yes, specifically B-cell non-Hodgkin's lymphoma, usually a low-grade type called malt lymphoma, often arising within the salivary glands themselves. It's a critical factor in their long-term health monitoring and management.
That is definitely important to be aware of, those connections between conditions. Okay, let's transition now to the more serious side, neoplastic disorders, or tumors of the salivary glands.
Right, salivary gland tumors, they're relatively rare overall, accounting for maybe 2 to 6.5% of all head and neck neoplasms.
So not super common, but significant when they occur.
Exactly. They tend to be slightly more common in women, often diagnosed in their 60s and 70s. And the parotid gland is by far the most frequent site. About 80% of salivary tumors arise there.
Parotid again. Seems like the hot spot.
It is. And when we're discussing salivary gland malignancies, specifically the cancers, there's a critical prognostic factor that recent studies have really highlighted.
Okay.
It's tumor size. For many salivary cancers, the size of the tumor when it's diagnosed is often more important for predicting the overall outcome than the histologic grade, how aggressive the cells look under the microscope.
That's interesting. Size matters more than grade sometimes.
It can be a very powerful predictor, yes. We use the standard TNM staging system, of course, which incorporates size, node involvement, and metastasis.
Right. Okay, let's start with the hopefully good news first, the benign tumors, which is the most common.
The undisputed king of benign salivary tumors is the pleomorphic adenoma, PA, also known as a benign mixed tumor.
Pleomorphic adenoma, okay?
It accounts for the vast majority, maybe up to 85%, of benign parotid tumors, and about half of minor gland tumors, where it often shows up on the palate.
And what are they like?
Typically, they present as slow-growing, firm, mobile, and painless lumps. Patients might notice them for years before seeking attention.
Slow and painless. Sounds relatively harmless.
Usually. So surgical excision, removing the tumor is the key treatment. And this is a vital insight, benign doesn't mean ignore. If pleomorphic adenomas are left untreated for a very long time, or if they're incompletely removed and recur, they can not only reach gigantic sizes, truly massive, but they also have a potential for malignant transformation. The risk increases over time, and with recurrence, potentially reaching up to 25%.
25%. So it can turn into cancer.
It can turn into a carcinoma ex pleomorphic adenoma, which is often aggressive. And there's even a more fascinating and frankly concerning variant called a metastasizing pleomorphic adenoma.
Metastasizing. But it's benign.
That's the paradox. The tumor itself, under the microscope, looks benign, just like a regular PA. But somehow it gains the ability to spread, usually to bones, lungs, or the abdomen. It behaves like a low-grade malignancy and can have lethal potential.
Wow. That is incredibly deceptive. Really highlights the importance of complete removal, even for benign PAs.
Absolutely. It's a powerful reminder that vigilance and proper surgical management are crucial. There are other less common benign types too, like Warthin's tumor, which is strongly linked to cigarette smoking.
Smoking, yeah.
And others like oncocytomas, basal cell adenomas, but PA is the big one.
Okay. So moving now to the malignant tumors, the cancers. What's the most common one we see there?
The most common malignant salivary gland tumor overall and in the parotid is mucoepidermoid carcinoma.
MECCA. Mucoepidermoid carcinoma. MECCA.
Yes. It accounts for maybe up to 30% of parotid malignancies and around 35% of minor gland cancers. And interestingly, it's also the most common salivary malignancy found in childhood, although still rare then.
So it spans all ages. What's important about MECCA?
The critical thing about MECCA is that it's graded low, intermediate, or high grade based on its microscopic appearance. And the stakes here are quite high depending on that grade.
How high?
Well, low-grade MECCA generally has excellent long-term survival rates, often 90, 100% at 5 or even 15 years.
Well, that's good.
But for high-grade MECCA, which behaves much more aggressively, those survival rates can plummet dramatically, sometimes down to 0.22% long-term.
Wow, huge difference based on grade.
Massive difference. So treatment varies significantly, too. It can range from wide local excision for low-grade tumors to more radical resection, often including neck dissection to check lymph nodes, and frequently post-operative radiotherapy, especially for high-grade or advanced disease.
Okay, grade is paramount for MECCA. What about Adenoid cystic carcinoma, ACC, you mentioned that one earlier.
Right, ACC. This is generally considered a high-grade malignancy, although its behavior can be complex. It's particularly known for a couple of things.
Like what?
First, it often causes pain or presents with neurologic findings like facial numbness or weakness much more frequently than other salivary tumors. That's because it has a notorious tendency for perineural invasion, meaning it likes to grow along nerves.
Invading nerves. That explains the pain and neurologic signs.
Exactly. Microscopically, it often has distinct patterns, sometimes described as Swiss cheese or cribriform, but prognostically, ACC is tricky.
Tricky how?
It often shows relatively good 5-year survival rates, maybe 70–90%. But unlike many cancers, the survival curve continues to drop significantly over time. At 10 years, it might be 30–70%, and by 15 years, it can be less than 50%.
So it has a tendency for late recurrence or metastasis.
Exactly. Distant metastasis, often to the lungs, can occur many years after the initial treatment. That pattern of late recurrence is a defining and challenging feature of ACC. Poor prognostic factors include tumors larger than 4 centimeters and having a significant solid component microscopically.
That long-term decline makes it particularly insidious. For most of these salivary gland malignancies, what's the general primary treatment approach?
Surgery is almost always the cornerstone, the primary treatment. The goal is complete removal of the tumor with clear margins.
Makes sense.
Radiotherapy often plays a crucial role as well, typically used after surgery, adjuvant therapy, for high-grade tumors, advanced stages, positive margins, perineural invasion, or recurrent disease.
Okay, surgery plus or minus radiation. What about chemo?
That's a crucial insight for you, the listener. Currently, for most primary salivary gland cancers, there is no established role for conventional chemotherapy as a standard part of treatment. It's generally not very effective against these specific tumor types, though it might be considered in very advanced metastatic or palliative situations.
Interesting. So chemo isn't usually part of the plan.
Not typically for the initial curative intent treatment, no. Research is ongoing into targeted therapies, but standard chemo is the mainstay, like it is for some other cancers.
Okay, so we've covered the conditions, the diagnosis, the tumors. But it's important to acknowledge, I think, that when surgery is necessary, especially on the major glands, it comes with its own set of potential considerations and complications.
Indeed it does. Salivary gland surgery requires meticulous technique because of the nearby structures. The major complications primarily involve potential neurologic injuries.
Nerves again.
Yes. Specifically for parotid surgery, remember, that's where most tumors are.
Right.
There's a significant risk of injury to the facial nerve. The facial nerve, which controls all the muscles of facial expression, actually runs through the parotid gland, dividing it into superficial and deep lobes.
Runs right through it. Wow, that sounds tricky.
It requires very careful identification and preservation of the nerve branches during surgery. Temporary weakness is common due to stretching or bruising, but permanent injury is a serious potential complication.
Okay, facial nerve is a big one for parotid. Anything else?
Another notable, though less severe, complication after parotid surgery is Fraze syndrome, also known as gustatory sweating. Patients experience sweating and sometimes flushing of the skin over the parotid area, but only when they're eating.
Sweating when you eat, how does that happen?
It's thought to be due to nerve regeneration gone wrong. After surgery, the nerve fibers that originally told the gland to produce saliva might mistakenly regrow to innervate the sweat glands in the overlying skin, so the signal to salivate also triggers sweating.
Bizarre. Can it be treated?
Yes, thankfully. It can often be effectively treated with, guess what, botulinum toxin injections into the affected skin.
Botox again. Comes in handy.
It really does in this field. And for submandibular gland surgery, the main nerve risks involve potential injury to the marginal mandibular branch of the facial nerve affecting the lower lip, the lingual nerve, sensation to the tongue, and the hypoglossal nerve, tongue movement. Careful dissection is crucial there too.
Lots to consider with the surgery. Wow, what a journey into the world of salivary glands. I mean, from their everyday wonders and that astonishing output.
1.5 liters.
To the complex diagnostic puzzles, the stones, the cysts, the autoimmune links, and the spectrum of tumors. We've really covered a lot in this deep dive.
We certainly have. It really highlights just how much our bodies are constantly working in sophisticated ways we rarely even think about, doesn't it?
Absolutely.
And how a detailed understanding, even of something as seemingly small or simple as a salivary gland, can make a huge difference in someone's health and well-being.
So what does this all mean for you listening? Well, maybe next time you feel that tingle before eating, or notice an unexpected change in your mouth or neck, perhaps you'll remember this hidden, tireless world working just beneath the surface. And it makes you wonder, doesn't it, what other seemingly minor body parts are doing incredible unsung work that you take for granted every single day.
That's a great thought to end on.
Thank you so much for joining us on this deep dive.